back, dear colleagues. And now let's have a brief discussion on hypo and hyperactivity symptoms related to norepinephrine disturbances. One way to think about this is to think about the RDoC criteria. So the RDoC criteria, which look at psychiatric disorders quite differently, not in DSM-5 terms, but in the symptom clusters patients have. For example, negative valence, which is threat, anxiety, things of that sort. Positive valence, which is, do they get a rewarding feeling when they engage in important things? Are they responsive to hedonic drive? What about cognition? Are they able to focus or not able to focus? How is their memory? What do they think about? So cognitive. Of course, social. Are they under-engaged in their social activities? And of course, arousal. Arousal in terms of, do they have nightmares? Do they have sleep difficulties? Do they have flashbacks? Do they have anxiety? Do they have panic attacks? This is a different way of looking at things, and these, all five of them, can be severely disrupted by norepinephrine. Now you see why when you look at DSM-5, but also the RDoC 5 criteria, we become very alerted to the fact that, oh my goodness, yes, norepinephrine plays a big role, definitely in top-down control of emotions, as you can see here. But when there is suboptimum performance of the norepinephrine system, primarily through the locus coeruleus, we can have an individual who's really buffeted between two opposites. They might have symptoms of hyperarousal, but not have the cognition to be able to suppress their negative thinking or worried thinking. So everything goes wrong. It becomes almost like a tornadic activity where the top-down control is too weak because there isn't enough norepinephrine, but the bottom-up signaling can get too much because there's way too much norepinephrine, and it's the poor patient who's caught between symptoms of too little and too much at the same time, in the same brain, at the same moment. Do you see how norepinephrine abnormalities can really genuinely trap a patient? Now, when we look at specific disorders, there's actually more worries. In some disorders, let's just look at agitation in Alzheimer's disease. Certainly, such patients can be fearful and anxious and worried, and that can lead to norepinephrine challenges. But on top of that, because of patterns of neurodegeneration, locus coeruleus functioning may be excessive in these individuals because they have lost some of the inhibitory GABA interneurons. That's just part of the disease. But because that has happened, locus coeruleus may fire too much, erratically, and that can lead to irritability, agitation, sleep disruption. So yes, norepinephrine does seem to be involved even in disorders such as agitation and Alzheimer's disease. And without a question, in post-traumatic stress disorder, PTSD, there are 4 classic clusters of symptoms of PTSD. In every single phase, norepinephrine has a habit of intruding itself into the symptomatology. So some of the classic symptoms of PTSD tend to be nightmares and flashbacks and anger and agitation. But by the same token, the very same patient may exhibit symptoms of withdrawal, not wanting to engage in things, having trouble concentrating, having trouble motivating themselves. It's a tale of two cities where we have a challenge of too much and too little, and that leads to significant trouble for the patient. And of course, the clinician might be confused. What am I supposed to do? Am I supposed to drop the norepinephrine or increase the norepinephrine because the patient has symptoms of both? And as Charles Dickens said, because it's a tale of two cities, our goal is to do both. And you're saying that's complicated. While it is complicated, that in fact is the goal of modulating norepinephrine even in this disease state. And lo and behold, norepinephrine also plays a role in schizophrenia at all levels. So all the way from genetic predisposition to the fact that even before symptoms of schizophrenia appear, there's evidence, there's emerging evidence that locus coeruleus functioning in such individuals, even before their first episode of psychosis, is impacted. Therein lies the reason why some of the earliest prodromal symptoms of schizophrenia tend to be social isolation, intermixed with agitation. Just talk to families. They will say the patient has occasional intermittent outbursts of anger and agitation, but other times they are very withdrawn. And of course, cognitive symptoms are unusually common in our patients with schizophrenia, which makes us believe that norepinephrine may have a role to play even in this disorder. So the panel discussion, and I think these are so important, let's cover them in some detail. Norepinephrine dysfunction shows up in a transdiagnostic manner. So norepinephrine doesn't seem to follow the laws of DSM-5. It chooses to intrude into multiple disorders. Definitely it can intrude in major depression. It can intrude in post-traumatic stress disorder. It can intrude in agitation in Alzheimer's disease and many, many other disorders. There's compelling reason to believe norepinephrine is disrupted in the disorders we talked about, and it simply does not follow the you gotta stay in your lane kind of rule. It crosses all boundaries. As a result, it is very important for us clinicians, not to be monolithic in our conceptualization of the various neurotransmitters. So, keeping in mind that norepinephrine, along with its friends, serotonin, dopamine, glutamate, and GABA, are quite involved in the pathogenesis of these various conditions that on the surface seem unrelated. But when you look under the surface, there's a common theme of connectivity. Thank you very much for hearing me on this section talking more about norepinephrine.